session. So Dr. Sebastian joined us at Emory in 2012. She is an assistant professor of medicine. She did her medical school training at Boston University and her residency here at Emory University. She did her gastroenterology fellowship training at Case Western University. Dr. Sebastian, in addition to what she's going to talk to us today, has an interest in colon cancer screening, but is also very involved in women's health in general as it relates to GI conditions. She is nationally, she is part of the American College of Gastroenterology Women in GI Committee. And she has, during her years here at Emory, she has established an Emory Women's Center that specializes in colorectal cancer screening in women, functional disorders, pelvic floor disorders, in addition to general GI and motility disorders. So that is one of her areas of focus. She also has an interest in celiac disease, nutrition as it relates to that. And today she's going to talk to us about colon cancer screening with a focus on the revised guidelines, appropriate methods for screening, as well as barriers to colorectal cancer screening. So I want to welcome Kavya, Dr. Sebastian. I just have two things about housekeeping. If you could all mute yourself during the presentation, and in terms of questions, we'll do the questions. You can put them in the chat, and we'll be, addressing them towards the end of the session, both the sessions, and the speakers as well as myself will be moderating the chat. So with that, I'd like to turn it over to Dr. Sebastian, and thank you.
Thank you, Dr. Srinivasan. Let me know if you can't hear me okay. And thank you all for inviting me to give this talk today. This is a topic that is near and dear in the hearts of gastroenterologists everywhere. As Dr. Srinivasan said, I will be discussing updates in colorectal cancer screening. To start off, I have no conflicts of interest or financial disclosures. So when most people think of March, they think of the color green, St. Patrick's Day, green beer, green potatoes. For us, that's often when we think of the color blue. This is Colorectal Cancer Awareness Month, and if you see many of us wearing blue ribbons, this is why. So this is a wonderful talk that we're passionate about today. What I hope you will get out of the talk is that I will be able to highlight for you some emerging trends in the presentation of colorectal cancer. I will review some of the new guidelines that are coming out for screening of colorectal cancer. I'll discuss appropriate methods for screening patients for colorectal cancer. And then I would like to touch on some of the barriers we need to get through to better screen our population for colorectal cancer. So let's start with a little background, what we know to date. So who gets colorectal cancer? And the answer is a lot of people. So in the US, you can see that after breast cancer and prostate cancer, as well as lung cancer, colorectal cancer is actually the third leading cause of cancer diagnoses. And we think of this because breast is predominantly women and prostate is all men. So for men and women combined, it is the third leading cause of cancer diagnosis. On this side, you can see that for cancer-related deaths, it is actually only second to lung cancer. So it is something that is actually very important and overlooked by a lot of patients. When we break it down by race and ethnicity as well as gender, you can see that the take-home subjects here are the African-American population are at increased risk, particularly the men outstrip people in terms of their rate per 100,000 people. Yes? Oh, sorry, I thought somebody was talking to me. On the women's side, a little less of a margin, but still a predominance there as well. The people who are on the lower end are Asian women, and Hispanic women seem to have lower than average risk. And this is mirrored by the death rate as well. You can see again that unfortunately, Black men have a higher rate of dying from colorectal cancer. And again, Asian women and Hispanic women are slightly below average. The typical trend over the last several decades has been that it's an older person's disease. The median age of diagnosis is around 67, and you can see it kind of peaks in the late 60s and drops off into the early 70s. One thing worth noticing, and what we're going to talk about a little bit today, is that this number in the 45 to 54 category is up to 15%, where it was 10 to 11% a couple of years ago. But still, the majority of colorectal cancer is again diagnosed in an older age range. And as a subsequence, most of the deaths also occur in the late 60s to early 70s, with a median age at death of 72. So average 5-year survival is about 65%, which is not terrible, but obviously lots of room to improve. And that is because if you look at this pie, here you have your localized disease, and here you have your regional disease. That's almost 75% of the pie there. And this also portends good outcomes. So this is one of the huge reasons we stress to patients that we can actually make a difference. There are many cancers where we cannot catch it fast enough, but colorectal cancer, we actually can. This is almost a 90% 5-year survival rate if we find localized disease. And something to stress to patients who say, oh, I'm 55, but I've never had symptoms, I have no family members, I don't need to get screened. This is why we want to screen. And as you can see, so 1975 is about where we considered the current era of colorectal screening has started. This follows almost 45 years of data. And you can see that if you track the data over time, there's almost a steady 2 to 2.2% drop in the rate of new cases going into the late 2010s. Similarly, the death rate goes down as well. And if you look at the 5-year survival rate, it similarly goes up. About 50 years ago, we were barely at the 50% mark, and now we're starting to get closer to 70%. So on the one hand, this is all encouraging data. However, there are some emerging trends that you need to be aware of. So data from the last couple of decades shows that there is continued decline in the CRC incidence amongst people who are 50 years of age or older. And this is thought to be due to large campaigns on colorectal cancer screening with promotion of stool-based studies, colonoscopy, as well as highlighting lifestyle changes, minimizing red meat, encouraging diet, exercise. However, concurrently, we have seen a 51% increase in the incidence of CRC amongst those under 50, starting in about the mid-90s. Increased incidence in particular has been notable for rectal cancer, which doubled 2.6 per 100,000 population in 1991, up to 5.2 out of 100,000 individuals in 2014. And this is for the 20 to 49-year-old adults. It's been projected that individuals born around 1990 have twice the risk of developing colon cancer and 4 times the risk of developing rectal cancer compared to somebody born around 1950. And this is held steady. You can look and see that, this is the 50 plus category, and this is the number of colorectal cancer cases per 100,000 people in the population. You can see it initially climbs up after the institution of the modern era of colorectal cancer screening. I would assume this is likely due to just increased screening, but you can see after that it steadily goes down in both men and women. However, these are our 20 to 49-year-olds, and you can see that after an initial dip, somewhere in the mid-90s, men and women both start to increase. So if you had about 10 cases before, you're almost up to 15 cases per 100,000 people. So in bare bone numbers, small, but again, if you look at the incidence, we've gone up from about 10% of the population to 15% of the population. And this seems to be carried forward as a birth cohort rather than a flash in the pan in one given year. Modeling studies by the Cancer Intervention and Surveillance Network have projected that lowering the average risk screening age from 50 years to 45 years would gain about 25 more life years per 100,000 individuals screened. They also noticed that this seems to be a similar trend in other developed nations, which makes us question, is this due to Western lifestyle, higher fat diets, lower fiber, more processed foods? Obviously, America, as are many Western countries, is in the middle of an obesity epidemic, possibly a more sedentary lifestyle compared to 50, 60 years ago, and then possibly exposures we're not aware of, environmental exposures, medications, things that we aren't even aware of yet. And so based on all this evidence that came out by the mid-2010s, the American Cancer Society were the first people who came out and strictly said in 2018 that they recommended that regular screening for average risk patients for colorectal cancer should begin at 45. And they said either with a stool-based test or a visual exam such as a colonoscopy. And we'll get to some of these other recommendations in a bit. The other societies dragged their feet a bit, and part of the anxiety was that it would increase people's concerns without saving enough lives, that it might require more healthcare resources, that maybe this was a passing blip on the radar, but not a steady trend. However, as of this past year, the US Preventative Services Task Force drafted an update in October of 2010, and it's currently in progress and should come out this year, saying that recent epidemiological data suggests that colorectal cancer incidence amongst current 45-year-olds now approaches that seen in a 50-year-old in the era prior to routine screening. So they finally came out, and again, this is a draft, but they are planning to come out recommending that we do begin colorectal cancer screening for the 45 to 49-year-old population. Now look at the gradings. It's still the more solid evidence we have from years and years of data is for the 50 to 75-year-old category. So this gets an A, but it's a more novel recommendation, but they are coming out with a slightly weaker recommendation to start screening amongst 45-year-olds to 49-year-olds. Our very own American College of Gastroenterology, which is one of our major societies, came out with guidelines as of this very month, and they updated their guidelines. And again, they kind of mirror what the Preventative Task Force is saying. Their language is, we recommend CRC screening in people between 50 to 75, and they say that's a strong recommendation with moderate quality evidence. They say they suggest colorectal cancer screening in average risk individuals between 45 and 49 years of age, and that's a conditional recommendation with low quality evidence. And a lot of this is because we still don't have solid data, nor do we have data going forward that we can make a difference by screening this population. So why or why not should we? So some of the benefits of starting to monitor this trend and going ahead and starting to screen people 45 and up is it obviously allows us to pick up colon cancer earlier. If this is going to be a continued trend. It reduces colorectal cancer risk because these people who come in earlier and get detected who have advanced adenomas are less likely to go on to colorectal cancer. And then that trend would be carried forward as these people age into 50 and beyond. We would make an impact on their later life. And then finally, some epidemiologists point out that while obviously all death from colorectal cancer is devastating, there's a particularly huge impact on society from the loss of people only in their mid-40s, as on a personal level, they're often sandwich generation, taking care of both young people who are not independent and elderly people who may be dependent upon them, as well as in the workforce. We're in an older country. A lot of our population is aged, and it's helpful to have younger people who are in the workforce and supporting that. So they say this is a particularly different social impact. What are some of the drawbacks of screening earlier? So first of all, false positives. It can cause a lot of anxiety, can lead to further testing, possibly procedural complications, both from testing for colorectal cancer as well as other tests it generates, greater healthcare costs. This also will add 21 million people who need to be screened on top of the people we already have. And one of the things I'm going to discuss later is how behind we are in screening in general. And so some people have raised the concern that the resources required to add this many people to the pool will actually detract from the ongoing efforts already for the 50+ population. And then as with any new recommendation, insurance tends to lag. So this is going to be a little complicated for patients as these guidelines change. So some thoughts for the future as I wrap up this particular part. We will definitely need to assess the cost versus benefit as we begin to implement these screening guidelines to begin including 40 to 49-year-old patients. One thing to think about as we go into the rest of the talk is modality. Should we be using a different modality for younger patients versus older patients to help get everyone in for screening? And then An interesting caveat is thus far we have not seen that the risk for the African American population is exaggerated amongst the younger patients. In other words, it doesn't seem that they need to start even earlier if the general population is starting at 45, say that they don't need to start at 40. So far we don't see any such trend, but that's something I was thinking we would need to watch as well. So again, look out for these guidelines coming forward. The evidence is not as strong because we don't have as much data yet as we do for the 50 plus, but right now it is going to change in the coming year that it'll start being recommended that people 45 and up get screened for colon cancer. So moving into the rest of our talk, so let's talk about colorectal cancer screening for average risk individuals 50 years of age and over. So again, the guidelines have not changed on this. They have strong support of people between 50 to 75 years of age being screened for colorectal cancer. One thing that's really highlighted, and I'm going to go into, is we recommend colonoscopy and or FIT as the primary screening modalities for colorectal cancer screening. And that's pretty strong evidence. And there are different ways to approach screening. And as you guys are all primary providers, you understand this. You can either give someone multiple options and say, here are a couple options, here are the pros and cons, here's how much it'll cost. You could do sequential testing where you say, I think you should really start with a colonoscopy. If you don't want to do that, here are some other options. Or you could do a risk stratified approach where you try to gauge who is higher risk and who is lower risk and try to screen them with the best test that you can get them to get done. I will say that I think most of us in GI typically go for the sequential testing where, because colonoscopy is the gold standard, we tend to offer it first and then do a backup test if they aren't interested. I know that in some of the VAs, particularly we've seen in the last couple of years, we've been behind. So often they will do a risk stratified approach. But all of these are appropriate. So tier 1 is really colonoscopy every 10 years or an annual fecal immunochemical test, which I'll abbreviate as FIT or FIT for the rest of this talk. This is mostly what I'm going to focus on because this is really where we stay. In tier 2, I will briefly address the fecal the FIT fecal DNA every 3 years, which you guys know is Cologuard most likely, just because it comes up so much. But really, those are the tests we're going to focus on. The rest of these are not things we standardly do. So colonoscopy, so 100% detection rate for colorectal cancer screening and has a good CRC mortality reduction, somewhere between 65 to 85%. One of the big pros compared to any other diagnostic test out there is that this is actually therapeutic as well. So obviously we use a thin flexible tube with a light and a camera on the tip, go all the way around the colon after the patient has completed a bowel prep, and with sedation for comfort, we're able to directly visualize the colon, and we can pass instruments through the channel so we can actually resect a polyp, biopsy a cancer. So this is why we consider it the gold standard. None of the other tests can actually be therapeutic. If they have normal tests, it's actually a very infrequent interval repeat, 10 years, which is really good compared to other tests. Some of the drawbacks, it is operator dependent. Generally, it's advised to have a gastroenterologist perform a colonoscopy for screening rather than a colorectal cancer surgeon. And that's simply because of how many cases a gastroenterologist does, as well as the type of training they receive. You do have to do a bowel prep. Some people have electrolyte disturbances or become dehydrated or vomit. It's unpleasant. Sedation, people can do it unsedated, but the vast majority of patients choose to do it sedated. And like any sedation, there are side effects from that. Risk of complications are not actually terribly high. About 4 in 10,000 can sustain a perforation. About 8 in 10,000 can sustain post-polypectomy bleeding or bleeding from other reasons. There are very rare complications such as splenic avulsion, where if the spleen was tethered very closely to the bowel, looping and torquing through the bowel may actually avulse the spleen. Obviously a major surgical emergency, but extremely rare and uncommon. There's also a missed adenoma detection rate. This increases as the size of the polyp goes down, so it can be as high as 20 to 25% in polyps less than 5 millimeters, and as low as 1 to 2% by the time your polyp gets over a centimeter. And some things that your patients should bear in mind and that you can assist them with when they're trying to pick a gastroenterologist is what is the adenoma detection rate? So on average, a gastroenterologist should be at the 25% mark, higher in males because of greater predominance, so 30% and 20% for females. Cecal intubation rate, so there should be clear documentation with photographs at the end of the report that they saw the appendiceal orifice, they saw the ileocecal valve, or if they were unsure, they tipped into the terminal ileum. This should be over 95%. And honestly, at this institution, I can say that I think most of my colleagues and myself can count on one hand the number of times in a year it happens. It's really close to 100%. Split dosing bowel preps. Patients hate this because especially if you're an 8 a.m. case and you have to be there by 7, you're finishing that last fourth of your bowel prep early in the morning, and then you have to be NPO for 2 hours before you get sedation. The reason we torture people with this is because it actually results in better preps and therefore increases our adenoma detection rates. And that's been shown in the literature. So this is standard of care. And like I said, you do need to have photographs documenting that the entire colon was examined, and they should comment on the bowel prep quality because that affects timeline to follow up. So moving on to FIT, which is our other tier 1 stool screening method. So FIT sensitivity is about 80%. Specificity is not bad, 95% for colorectal cancer. The way this test works is it's not like the old FOBT where you have to do 3 samples and you can't eat certain foods. This detects human hemoglobin in the stool. So you don't have to alter your diet. You don't have to stop blood thinners. This is something that can be mailed to the patient from their PCP's office. They just need a one-time smear on the equipment and send it in within 24 hours. Obviously non-invasive, no complications, can be done privately at home. One of the drawbacks of any other test besides colonoscopy is if it's positive, it does require a colonoscopy for follow-up. It is an annual test. So unlike colonoscopy, where if it's normal, you go 10 years, you do have to do this annually. It has pretty low sensitivity for picking up advanced adenomas and does not detect sessile serrated polyps. But again, this is a good option for a lot of average risk screening patients, but only average risk. And that's also another key thing for anything other than colonoscopy. It's only for average risk screening. A word again about the multi-target stool DNA test. So this is basically, this is in tier 2, and I'm going to talk about why in a second, but this combines the FIT test with markers for abnormal DNA. It does increase the sensitivity for CRC up to 92%. It's actually about the same for specificity. It's non-invasive, again, can be done at home. Better sensitivity for advanced adenomas and serrated flat lesions compared to FIT by itself. Now, again, positive tests require colonoscopy. One problem is we don't actually know, there's not good data on the interval that we should be doing, but it's been proposed about 3 years. It is expensive. So FIT is about 20 to 30 bucks. This test is upwards of $200, even up to $600, depending on your insurance. The other problem we were running into when this first came out and people started doing it was that as gastroenterologists, we'd feel anxious when we had a positive test and a negative colonoscopy. And initially, people were going through batteries of other workups to find something to explain the abnormal DNA. So they'd get an upper endoscopy and a CT scan and a pill cam and all these other kind of things. And what we realized long term is that that's not appropriate. It's currently not recommended that someone who has a positive test undergo further workup if they've had a negative colonoscopy. So do be aware that there's a high rate, not a high rate, but there's a rate of false positives. This is why it's in tier 2 instead of tier 1. It's thought that when you assess cost effectiveness and what you're gaining from that slightly extra sensitive test, you're not actually saving a whole lot more lives or catching a whole lot more cancer. And it's not cost effective and generates a lot of anxiety and unnecessary testing. But I just wanted to put in a word of it because they've done great promotional campaigns, and I think this is very popular amongst patients. So you're probably going to see it used. So moving along, a quick word about high-risk screening patients. So I'm not going to dwell on this. This is a whole separate talk by itself. But just be aware, if you have patients who report lots of family polyps, like someone who had to have their colon out because they had hundreds of polyps, think FAP, Lynch syndrome, if patients say that someone had a mutation in their family and has to get frequent colonoscopies, these are things that should trigger you to send the patient to genetics and GI. Same thing goes for patients who have had IBD for close to to a decade. And then family risk. So one thing to point out in family risk is it's about age. So if it's a first degree relative over 60 years, then under 60 years of age, they are at increased risk. So they need to start at 40 or 10 years younger than their index family member. And even if it's normal, they have to have a colonoscopy every 5 years. It also has to be a colonoscopy. Whereas if the first degree relative, and if there's only one, because if you have multiple relatives, that starts to change. But if it's one first degree relative who's like 78, they start at 40 or 10 years younger than that member, but they can use any recommended screening test. And after they're done, if they're normal, they go back out to average guidelines. And then finally, anyone with a personal history of cancer, we should rescope them 1 year after diagnosis, then at 3, and then at 5. So when should we stop screening? This is a popular topic recently with our advancing age of our population. So obviously the main concern is as people get older, the life expectancy goes down. To get the benefits of polypectomy, where we're taking out small lesions that will turn into cancer, we're talking about 7 to 10 years. So if someone's life expectancy is less than that, we're probably not gaining anything from taking out small polyps and doing screening. Also, comorbidities start to go up. So just the sheer risk that someone will die from something else goes up. It's thought that there's about 15% or less increase in life expectancy compared to younger people. And obviously some of the risks of complications are the same here as they are with younger people: bleeding, perforation, cardiovascular problems, but they are not as well sustained by an older person. Over 75 years of age, we generally recommend that either you or us or both sit down with the patient and their family and have a discussion regarding the risks and benefits of continued screening, assuming they're in good health. And then over 85 years of age, you really shouldn't be screening. At that point, their risk of something else being fatal to them is much higher, and so someone should not undergo colon cancer screening. And again, different from diagnostic testing, but they should not undergo routine colon cancer screening. So barriers to screening. United States, we haven't been great. It's been a goal set for some time now that we want to get the whole population screened within a goal of 80%. But we've set that goal for several years in a row now. And you can see that as of 2020, we were still falling short. The median is about 69.7%. So we're hovering right at 70%. In case you're interested, Georgia is slightly below that. But you can see some parts of the country are worse, some parts of the country are better. It's actually about even between genders. They've kind of flip-flopped over the years in the last 2 decades, but you can see that both men and women have kind of risen towards this 70% line together. If you do it by race and ethnicity, non-Hispanic whites seem to be slightly higher than average. We are behind in screening our African-American population as well as our Hispanic population. In terms of poverty level, it's probably not surprising, unfortunately, due to access. People who are at greater than 200% of the poverty level are pretty high, as opposed to people who are less than 200% of the federal poverty level are much lower, under 60%. And then finally, education. The people who have greater than high school education are closer to 70%. And by the time you get to less than high school education, it's quite low. It's actually dropping close to 50%. So this, again, could be a whole talk in and of itself, but how do we improve access to colorectal cancer screening? So this is where, on the provider's end, certainly some electronic medical records help us by prompting us or sending ticklers. In-depth patient education by the provider, even if it's not us, a really good relationship with a primary provider has been shown to increase the likelihood that people will sign up for colorectal cancer screening. Good old-fashioned mail and brochures has been proven to be successful. For the younger generation, text reminders. Reduction in difficulty of getting screened. So as somebody who's been a patient in the Emory system myself, I've sometimes been on hold for 16 minutes trying to get a routine appointment. So they found that when they've employed navigators in some medical centers, this has actually helped, particularly for people with language barriers or for elderly patients. And then finally, outreach and promotion on a grassroots level, reaching out to the community. So with the little time I have left, I did want to briefly touch on colorectal cancer screening during the COVID pandemic, because this has further affected us. So This is from the San Francisco Health Network. They did a study just to look at their numbers and decline in screening back February through May of 2012. So similar to a lot of us, if you use here, they saw their first case in the area in March 10th, they saw their first COVID patient, and you can see there's a steep drop off in the in-person visits, which is this dark circle, as well as FIT tests ordered. You can see colonoscopy plummets around here, and these open circles are their telephone visits. FIT did recover a little bit. If you look, it starts to come back up in April a little bit. Colonoscopy was only just starting to recover in May. And that's true for a lot of us. We were closed around the same time before we opened our procedure suites back up. So they estimated that they decreased their FIT volume orders by about 85%. So 370 tests weekly prior to the pandemic, 60 tests weekly after. Volume of their colonoscopy also went down 90%. They were doing 150 to 200 cases a month, dropped down to 15 cases. And they extrapolated that nationally and said that if that persisted into June, we would miss 19,000 colorectal cancer diagnoses and have 4,000 excess deaths. We don't have further data from them to see how that played out. But I will say the good news is most centers opened back up by May or June and have done so safely, including ourselves. So we do want to catch up on that. But as you can imagine, there's a massive backlog of people who have not gotten in. We still have people who are scared to come in because they think they'll get COVID from coming into the medical center. And in the early pandemic, we were the first to say, you have a polyp or two that you had before, or you just are first time screening, sure, hold off. It's just a month or so. At this point, we do want to encourage patients that most of the providers are vaccinated. Risk of transmission in the medical center is extremely low. We're using PPE. They're happy to talk to, we're happy to talk to them if they have qualms, but it is important for them to come in and get screened, or alternatively, if they're willing to do a colonoscopy, if positive, possibly consider something like an FIT test. So in conclusion, colorectal cancer is the third most diagnosed cancer in the US and the second leading cause of cancer-related deaths. There is this unclear reason for increasing incidence of colorectal cancer in individuals under the age of 50, particularly 45 to 49, with new recommendations coming out to lower the first age of screening to 45. Different screening options available to average risk patients, and at the end of the day, the best test is the one the patient will complete. Just be aware of high-risk populations who may need earlier screening and should only be evaluated with a colonoscopy. Given the pandemic and the fact that we're already behind on screening our population, we do all need to make a concerted effort to promote colorectal cancer screening and make strategic use of these different screening modalities. And then finally, we are your friendly neighborhood GI. Please do not hesitate to reach out to us if you have questions or you want a patient to sit down to talk to us in depth about their concerns about colorectal cancer screening. Thank you so much for inviting me to give this talk today, and I want to allow Dr. Roccaro time to also give his presentation. Thank you.
Thank you, Dr. Sebastian. And we have a few questions in the chat that we will answer after Dr. Roccaro's talk. So I want to give a brief introduction to Dr. Roccaro. He joined us in 2018, joined the Division of Digestive Diseases and the Emory Transplant Center. He's an assistant professor of medicine here in the Emory, in the Department of Medicine. He's also a medical director of Inpatient Hepatology and also the medical director of the Living Donor Liver Transplant Program. He obtained his medical degree at SUNY Downstate College of Medicine, and then he completed his internship and residency at Mass General Hospital. He did both his gastroenterology and transplant hepatology fellowship at University of Pennsylvania, where he also obtained a master's in clinical epidemiology. And as I mentioned, he's very critical in terms of the living donor liver transplant program. And today he's going to talk to us about non-alcoholic fatty liver disease. He'll focus on epidemiology, natural history of disease, risk stratification, and how it relates to hepatocellular cancer. So thank you, Dr. Roccaro, and I will turn it over to you.
Thank you so much, Dr. Srinivasan. I appreciate that introduction. It is an honor to be here today. I will be discussing hepatocellular carcinoma in patients with non-alcoholic fatty liver disease. This talk was inspired by a recent American Gastroenterology Association guideline on the management of patients with non-alcoholic fatty liver disease and screening for HCC. I have no relevant disclosures. So I'm going to start with the case. This is a real-life case that is probably very familiar to those who are practicing in primary care. This is Mr. M, a 62-year-old man with insulin-dependent diabetes. He has hypertension, obesity, and osteoarthritis. You started him on a statin to reduce his cardiovascular disease risk 9 months prior. He's maintained mildly elevated aminotransferases fluctuating over the last 2 years, and his current labs demonstrate an ALT of 44, an AST of 51, albumin of 3.9, a platelet count of 170,000. You ordered an ultrasound which demonstrated increased echogenicity of the liver consistent with hepatic steatosis, and you recommended that he increase his physical activity and lose some weight, which he's been unable to achieve. You're wondering if you should refer him for further evaluation. So I'd like to take you through this vignette and hopefully at the end of the talk have a better sense of what to do in this scenario. I'll do that by first defining what non-alcoholic fatty liver disease is, which I'll refer to as NAFLD, reviewing the current epidemiology and natural history. We'll then delve into risk stratification, in particular, when should someone be referred if they're at increased risk for advanced fibrosis. We'll talk a bit about the intersection of NAFLD and hepatocellular carcinoma risk, and guidelines for HCC screening in patients with NAFLD and how they may not be optimal. And finally, we'll end with a shameless plug for the Emory Liver Tumor Clinic. So what is NAFLD? Basically, we define normal liver tissue to have less than 5% macrovesicular steatosis. So anything greater than that is referred to as pathologic steatosis. Many of our imaging modalities, particularly in ultrasound, won't really pick up excess steatosis until there's about 20% parenchymal involvement. And we define NAFLD as this occurring in the absence of excessive alcohol consumption. Really, NAFLD is an umbrella term for what, in my mind, is 3 distinct conditions. There's hepatic steatosis or bland steatosis, which is a relatively benign condition and non-progressive. Then there is hepatic steatosis accompanied by ballooning hepatocyte injury with inflammation, what is referred to as non-alcoholic steatohepatitis or NASH. And finally, there's NASH with advanced fibrosis. And that is really the entity that we in particular want to risk stratify and target for risk mitigation strategies. So this map reflects the current epidemiology of NAFLD in the presence of type 2 diabetes. So the global prevalence of NAFLD among patients with type 2 diabetes is about 55%, and nearly 1 in 2 in the United States. The highest areas of prevalence are in Europe, Latin America, and in the Middle East. In the US in particular, the prevalence of NAFLD is about 25%, so 1 in 4, with the highest among Hispanic Americans, roughly 45%. This prevalence has increased by 2.7-fold from the late 1980s to 2010, with the prevalence of NASH among patients with type 2 diabetes being roughly 1 in 3. And in the general population, depending on the studies that you look at, the prevalence has been about 1.5 to 6.5%, with an average of about 5% or 1 in 20 patients having NASH. This is a depiction of the spectrum of NAFLD, and I'd like to talk to you a little bit about the natural history of the disease. So if we look at the epidemiologic studies in the US, about 1 in 4 patients have fatty liver disease. This can progress over time to include inflammation and hepatocyte injury, what we define as NASH. The risk factors for that are obesity, diabetes, other elements of metabolic syndrome, age, and male gender. Roughly about 1 in 4 to 1 in 5 patients with fatty liver disease will then develop NASH over a period of time. Once patients have NASH over a long period of time, and this is very heterogeneous, they can develop advanced fibrosis. So NASH is a risk factor for developing advanced fibrosis. And it's roughly postulated that about 1 out of 10 to 1 out of 11 patients will develop advanced hepatic fibrosis over a period of 15 to 20 years. So this will equate to about 1 out of 160 to 1 out of 200 patients having chronic advanced liver disease due to fatty liver disease. This umbrella term is relatively new. Chronic advanced liver disease encapsulates a spectrum of patients with advanced fibrosis or bridging fibrosis, as well as cirrhosis. And that's really important because patients with fatty liver disease or just bland steatosis and NASH, those patients have increased mortality, but not due to liver-related mortality or liver cancer. They're at increased risk from non-hepatic malignancy and cardiovascular disease. However, in the presence of advanced fibrosis or cirrhosis, liver-related mortality comes to the top. So you have increased risk of dying from end-stage liver disease as well as hepatocellular carcinoma. To look at this in raw numbers, if you look at 1 in 160 to 1 in 200 adult Americans, this equates to currently 1.3 million adult Americans with chronic advanced liver disease due to fatty liver disease, and slightly more than the population of Dallas. And these are the patients who we have to target because of their increased risk of developing decompensation in the form of abdominal ascites, portal hypertensive bleeding, a variceal hemorrhage, as well as the development of liver cancer. So I'm going to touch on some easy, very low cost methods for risk stratifying for advanced fibrosis and how this can play into a primary care practice. So the first lab-based test we refer to is the FIB-4. FIB-4 was developed to predict advanced fibrosis in patients with HIV and hepatitis C co-infection. It was then subsequently validated in a subset of 541 patients with biopsy-proven NAFLD and had an area under the receiver operating curve of 0.8, so pretty good in detecting advanced fibrosis. The elements are age, the AST, the platelet count, and the ALT. And this formula is very sensitive to predicting advanced fibrosis using a cutoff of 1.45. So if the value of the FIB-4 is less than 1.45, you can be pretty reassured that the risk of the patient having advanced fibrosis is quite low. The second model is called the NAFLD fibrosis score. This was derived and validated in a sample of 733 patients, again with biopsy proven NAFLD. Using multivariable logistic regression analysis, they determined that age, body mass index, diabetes, ALT, AST, platelet count, and albumin were all independent predictors of advanced fibrosis. And a meta-analysis looking at 13 studies that looked at the NAFLD fibrosis score determined that the area under the receiver operating curve for advanced fibrosis to be 0.85. This is a picture of what the NAFLD Calc app looks like. It's one of my most used applications on my phone. You plug in all the relatively important variables, age, BMI, diabetes, the lab values, and that will give you the NAFLD fibrosis score. Using a cutoff of negative 1.45, you can pretty much exclude the likelihood of advanced fibrosis. So this takes me to a proposed algorithm for use in primary care. You have a patient with either a history of chronic elevated ALT or AST for at least 6 months, or a patient with type 2 diabetes and an additional component of metabolic syndrome, or a non-diabetic patient with 3 additional components of metabolic syndrome. These are the high-risk factors for advanced fibrosis in the setting of non-alcoholic fatty liver disease. You want an ultrasound to establish that they have NAFLD, and for those with chronically elevated aminotransferases, a serologic evaluation to exclude other causes like viral hepatitis. And of course, an alcohol intake history is very, very important. Using these readily available tests, the FIB-4 and the NAFLD fibrosis score, you can risk stratify. A low FIB-4 and low NAFLD fibrosis score below those thresholds would result in just a primary care follow-up and lifestyle modification to reduce cardiovascular risk and to manage metabolic syndrome, as those are the most pertinent causes of mortality in these patients, as well as age-appropriate cancer screening. For those with a FIB-4 that's greater than 1.4 and a NAFLD fibrosis score of greater than 0.676, those are patients to target for hepatology referral and for potential need for lifelong HCC screening and surveillance. So I'm going to talk a little bit about why HCC screening in patients with non-alcoholic fatty liver disease is so important. So this is data from the SEER database, and it reflects a pretty happy story of cancer in the United States, as we've seen some pretty remarkable decreases in incidence of cancer, as well as cancer-related mortality since year 2000. However, the story is not the case in HCC, where we've seen increasing rates of HCC-related death, as well as increasing incidence until about 2016. And there's been a slight dip downward, which may reflect the availability of direct-acting antiviral therapy for hepatitis C, as we're curing more and more patients with hepatitis C, and that might have now a downstream effect on the incidence of HCC. Overall, the annual risk of liver cancer in patients with advanced fibrosis due to non-alcoholic fatty liver disease is about 2 to 2.5% per year. And that is above the 1% threshold in which screening is cost effective. This has had significant implications on the transplant community as well. Since 2014, the number of patients with hepatitis C related end-stage liver disease on the liver transplant waitlist has plummeted due to curative therapy for hepatitis C. And these two lines depict alcohol and non-alcoholic related fatty liver disease registrants, and that has been continuing to climb, with now fatty liver disease being the second most common indication for liver transplantation. Among waitlist registrants with HCC, we've seen, again, plummeting decline in patients with hepatitis C related liver disease. And now, as of 2020, the most common etiology of liver cancer among patients waiting for liver transplant is fatty liver disease. In a study of Medicare recipients, NAFLD was the most common etiology of hepatocellular carcinoma. And in fact, the prognosis of NAFLD-related HCC seems to be worse than any other liver disease. In particular, it was compared to a control of hepatitis B-related HCC. Patients with NAFLD-related HCC were 87% more likely to die of a cancer-related mortality. When they adjusted for relevant confounders in the study, it appeared that the later stage of diagnosis and greater concomitant comorbidities in patients with NAFLD-related HCC explain the shorter survival time. And there's a clear relationship between the stage of diagnosis and survivorship in HCC. So therefore, screening and effective screening is very important to this condition. So back to our algorithms, you're looking at these non-invasive markers to help identify those at increased risk for advanced fibrosis and who should therefore undergo HCC screening. How can we apply this back to our patient? We use his lab values and we calculate a NAFLD fibrosis score of 3.5 and a FIB4 of 2.8. Those are above our thresholds, and therefore referral for further risk stratification is probably warranted. How do we go about that? Generally in hepatology practice, we'll use, again, further non-invasive testing means. The most common is transient elastography. Transient elastography is a technology which uses acoustic waves or shear waves to determine the stiffness of the liver parenchyma, which is expressed in kilopascals. The way I describe this to patients is a very healthy liver is like gelatin. So these shear waves will travel through the liver parenchyma very slowly. Whereas a stiff liver that has a lot of scar tissue and fibrosis, those shear waves travel quite fast. So therefore, the speed correlates with stiffness, and stiffness correlating again with fibrosis. And this has been validated in studies looking at patients who have biopsy-proven NAFLD. The area under the receiver operating curve of 0.93 for detecting advanced fibrosis in patients with an elastography read of greater than 12 kilopascals. And the degree of liver stiffness correlates with the risk of hepatic decompensation as well as end-stage liver disease. So going back to our algorithm here, we've performed further risk stratification using transient elastography. A score of less than 8 kilopascals reflects low risk, correlating with stage 0 or stage 1 fibrosis. Generally, we recommend continued follow-up with primary care and cardiovascular disease risk modification strategies, as well as age-appropriate cancer screening. A median liver stiffness of 8 to 12 is medium risk, correlates with kind of intermediate stage fibrosis. And these are patients who we make recommendations for intensive lifestyle modifications, both combinations of diet and exercise, targeting a weight loss, total body weight loss of about 5 to 10%. We keep patients in mind for clinical trial opportunities as there are more emerging potential disease-modifying medications that are on the horizon. And we monitor them probably on an annual basis to look at their liver function and to continue to risk stratify over time. For patients with an elastography read of greater than 12 kilopascals, these represent the advanced fibrosis patients who are at high risk. So we institute those same recommendations that we do for medium risk, but also institute HCC screening and surveillance. So back to our patient who had an elastography on a median liver stiffness of 12.5, we would recommend HCC screening and surveillance due to the high likelihood of advanced fibrosis, even without having performed a liver biopsy. What are the recommendations for HCC screening? So if you look at our society guidelines, the American Association for the Study of Liver Disease, they still recommend that all patients with cirrhosis, and don't really go into advanced fibrosis, but all patients with cirrhosis undergo HCC surveillance with an abdominal ultrasound every 6 months. The caveat to this recommendation is that the studies which form the backbone for which this recommendation was built on was conducted in populations and samples with a pretty low prevalence of fatty liver disease. So this recommendation for ultrasound-based screening may not be sufficient in a fatty liver disease population or a Western population, particularly in the US, where obesity rates are about 35%. To further investigate that, there was a really nice study done at UCSF of 352 patients who were undergoing liver transplant evaluation. And these are all of these patients had known HCC. So they compared their gold standard, which is cross-sectional imaging with MRI or CT scan with contrast, to ultrasound. And they found that ultrasound overall sensitivity was about 82%. For patients who were obese with BMI over 30, the sensitivity decreased about 10%. And for patients with NASH-related liver disease, the sensitivity was about 25% less, 59% versus 84%, and that was statistically significant. So I really like to keep this study in mind, particularly with patients who have both NAFLD-related liver disease and obesity, knowing that ultrasound might not be the best screening modality. And I will advocate for once-a-year cross-sectional imaging with MRI or CT scan, which often results in a battle with insurance companies. Screening is so important because the stage of disease dictates treatment and survival. And I don't include this slide because I hope to teach you everything about HCC treatment in less than 3 minutes, but I include this slide to demonstrate how complex the treatment for HCC is. HCC treatment is very complex because it must be tailored to patient's stage of liver disease, their stage of liver cancer, liver function, and their comorbidities. And it really requires a multidisciplinary approach, and care must be carefully coordinated in order to be effective for the patients. So with that, I want to plug our Emory Liver Tumor Clinic, which is a multidisciplinary care clinic. We'd like to demonstrate the care delivery model that we have developed here. So about a year and a half ago, we established a dedicated liver tumor clinic coordinator. And her name is Angela Majid, and she's been a phenomenal asset to this clinic because she helps shepherd patients through from referral all the way to care coordination. So she is in charge of receiving referrals, and once a referral is received, recognizes patient need and confirming that this is a hepatocellular carcinoma patient or a patient with another liver primary malignancy like cholangiocarcinoma. She will work on acquiring the patient's records and imaging and scheduling the appointment. And generally, we aim to achieve a turnaround time of referral to appointment of less than 2 weeks. Once the patient comes in for their evaluation, we do a pre-clinic huddle among all the providers so that we review all the patients for the day, understanding what their liver disease is, as well as what the tumor burden may be. The patients, once they're seen in the clinic, undergo rotating provider visits. So they'll see up to 4 providers, a hepatologist, a transplant surgeon, a medical oncologist, and a physician assistant from interventional radiology. And we schedule up to about 6 new patients per week. Following their clinic visit, which our clinic happens on Wednesday, on Friday morning, we have a multidisciplinary tumor board that involves members of radiology, interventional radiology, hepatology, transplant surgery, hepatobiliary surgery, as well as interventional radiology. We review the pertinent imaging as well as the clinical information gained from the clinic visit. And at the end of the meeting, we devise a multidisciplinary care plan, which is communicated back to the patient that afternoon, and care is coordinated. This has really amplified how care is delivered for patients with liver cancer within Emory. Prior to this multidisciplinary clinic, care was pretty much provided in silos, and there was a lot of disjointed care. It's also helped increase our volumes by having a dedicated coordinator and increasing throughput. So prior to the multidisciplinary clinic, we saw about 60 to 80 new HCC patients a year, and in the last 2 years increased volume from to about 140 patients last year and on target for 150 patients this year, 90% of which have been seen virtually, at least for an initial consultation. These are many of the faces of our liver tumor clinic. So in the top left is Dr. Joel A, who's been instrumental to devising the multidisciplinary HCC clinic, and he's our medical director. Here's myself back when I wore ties before the pandemic, and Dr. Sellers, our transplant surgeon. This is Mehmet Akshay, our medical oncologist with appointment at Winship, and Angie Majid, our coordinator, and Gerardo Sanchez, our physician assistant from interventional radiology. We can each be contacted individually if you have a patient who you'd like to refer, or you find an incidental liver lesion and want it to be looked at. And it could also be reached through the liver referrals pool in Emory. So to summarize, the prevalence of NAFLD has increased 2.7-fold since the late 1980s and will soon constitute the most common etiology of liver disease for patients in need of a liver transplant. The prevalence of chronic advanced liver disease due to NAFLD is now over 1 million Americans. Preliminary non-invasive risk stratification using readily available labs and data is a key tool in guiding referral practice. And HCC screening is essential for those with advanced fibrosis. Finally, exclusive ultrasound-based screening is likely not the optimal modality for patients with NAFLD-related liver disease and obesity. Thank you.
Thank you, Dr. Roccaro, for your presentation. So we're going to open it up for questions, and I'm going to request Dr. Sebastian, if she had a chance to go through the chat to answer some of the questions, and maybe you can read the question first.
Sure, Dr. Srinivasan. So Dr. Dressler, I will tell you the first question, I don't have an answer for you right off the top of my head, wondering what the number needed to screen is for the age range 45 to 49. I think this will be interesting to follow as we go forward, because as we said, it's not actually a strong evidence because we haven't done it thus far, and it's based on this slight increase in incidence we've been seeing. Which kind of leads me into your second part, also wondering if we have enough gastroenterologists to screen with colonoscopy the additional lower age population. So that's one of the concerns. If we're adding 20 million, 21 million people to the pool, are we going to have enough gastroenterologists? And I think this is where we are going to have to think a little bit more about multiple options rather than a sequential offering. I know for me, after the pandemic, I've had a slightly different approach to patients with whom I discuss screening. I have done the multiple option approach of here's FIT, here are the pros and cons. And you do have to tell them if positive, you would need a colonoscopy, and that's no longer considered screening, which could affect your insurance coverage. But a lot of people are willing to do that because there's a pandemic and they don't want to prep and they don't want to come in. And we may have to think about that to get more of that younger population screened. I'm curious to see going forward, as we start to implement this, whether we revoke it in the future if we find that it's actually not that effective and we're not significantly making a dent in the younger population. It's a great question. This next one is one I actually had meant to address and forgot to. Somebody from Midtown who asked, what do you think about the ACP recommendation to do CRC screening with FIT every other year? So I will say that from a GI standpoint, we do not recommend this. So one of the things that people thought when these things came out is, oh, maybe if we alternate modalities, we're going to improve it. We don't significantly detect more colon cancer because those pathways you've already chosen are adequate for screening. So if you have a perfect colonoscopy, the reason we say you can go 10 years is because the data is so strong to support the near unlikelihood that you're going to have colon cancer. So doing FIT then actually just increases the risk of a false positive, and then may lead to unnecessary testing. And we do see this happen. People who just had a normal colonoscopy last year now come back for another one this year, and it's diagnostic and not covered by insurance because they had a positive FIT, and often it's negative. Maybe they have some hemorrhoids that turned it positive. So we don't recommend alternating it. Once you choose a pathway, stick to the pathway, and then you can change again at that end pathway. So if in 2020 they do a colonoscopy normal, and 2030 they could choose to switch to FIT and do that every year, or vice versa. And then finally, what is thought to be the biological driver of the increase in incidence of CRC in individuals aged 45 to 50? They're not entirely sure yet, but sort of similar to what Dr. Roccaro is saying in NAFLD, we obviously are seeing an obesity epidemic. We are seeing more sedentary lifestyle. They are wondering if it's somewhat diet related, because it is more prevalent in developed nations who all have quote unquote a Western diet. So higher fat, lower fiber. But no, they haven't pinpointed one driving reason. And the other thing they don't know is, are there environmental factors that we're unaware of, something we're exposed to? For those of us born maybe after 1970 or so, you know, I mean, I'll be honest, I think about the things we took in our lunch boxes in the 80s, like Capri Suns and Dayglow Cheeto Puffs. My mother would be really upset right now, but that nobody knew, like all these lunch meats with nitrites. So it's not quite clear, but we think it's a combination of obesity and dietary choices. That's to the best of our knowledge right now.
Thank you, Dr. Sebastian. And there's a question for Dr. Roccaro. I'll let you address it.
Sure. From Amy Miller, what is the role of alpha-fetoprotein in HCC screening? So alpha-fetoprotein adds a very small increase in sensitivity for HCC detection, particularly for early stage disease. It's not a very large increase in sensitivity, so it's not been shown to be necessarily cost effective. Therefore, it's not in the AASLD guidelines. We will often, in patients with cirrhosis, send an alpha-fetoprotein, particularly if we're forced to rely upon ultrasound-based screening, in which we, for insurance reasons, can't get cross-sectional imaging for HCC surveillance. We'll send an alpha-fetoprotein, because if the ultrasound is unremarkable for liver lesions and we see an elevated alpha-fetoprotein, then we can often get cross-sectional imaging to hopefully exclude the presence of liver cancer. But there are a lot of conditions which cause false elevations of alpha-fetoprotein, particularly if patients have active viral hepatitis, hepatitis B or hepatitis C, or actively drinking alcohol and have hepatic inflammation. So there certainly is a role for it, but it's not part of guideline-based screening at this time.
Thank you. And there's a question from Mary Ree. She says, most of our middle-age to older diabetes patients will have NAFLD fibrosis scores of greater than 0.675. Would you recommend that we refer all these patients for fibroscans?
That's a great question. That reflects that the NAFLD fibrosis score coefficients in the actual model are heavily weighted for age and the presence of diabetes. So yeah. You know, your patients over 60 who have diabetes will more than likely screen positive. That's why I do recommend combining the NAFLD fibrosis score with FIB4 as kind of a two means test. And if those patients kind of both have cutoffs levels for FIB4 and NAFLD fibrosis score above those thresholds that I proposed, I definitely think they should absolutely have an elastography exam to stage their liver stiffness or fibrosis. In a lot of practices, particularly in rural settings, elastography is available in primary care offices. You know, it is technologist dependent, somewhat operator dependent, so it does require training, but in many places, particularly where they're providing indigent care, it's kind of a point of care testing where there's a high prevalence of fatty liver disease. So right now at Emory, kind of the best means for accessing FibroScan is through a hepatology referral. So, you know, if those two non-invasive screens are both concordant with high risk, I do recommend referring on.
So I want to thank you, Dr. Roccaro and Dr. Sebastian, for outstanding talks. There's lots of wonderful comments in the chat. Everyone seems to have enjoyed your talks. And thank you, everyone, for attending this session. I think we will end it here and have a good afternoon.